네, 반갑습니다.
Good afternoon, nice to meet you all.
이 세미나를 기획하면서
So during the planning process
있어야 된다고
of the symposium, I
생각을 해서
thought
하긴
there
했는데
should be a discussion.
왜 하자고
So I
했을까?
insisted
살짝
on it,
후회했죠.
but I
그리고 이
regret
시간까지
what I
남아주신
said. I would like to thank all the
여러분들한테
participants for staying
대단히 감사하다는 말씀을
until
드리겠습니다.
this late hour.
원래 마지막이 제일 중요합니다.
So the last is the most important, it's not the least.
오늘의 주제를 한마디로 요약을 하면
So if I am to summarize
의료의
today's
질량상이
topic,
굉장히 중요한데
is
모두
the
동의하시죠?
quality healthcare improvement. All of you agree to this. And if we utilize data, it will become much more better. So I think this is a summary of what has been mentioned extensively today.
의료질 향상을 위한
So in the first session, we have taken a look at
OECD의
the various cases. Before that, we had listened to keynote speeches based on the strengthening health data in OECD countries and also focus on PHC. And in session 1, we listened to cases from Korea, Denmark, and the UK. And under session 2, we have taken ways or activities done by OECD and ISQA as well, and also the activities that have been taken by HERA. So it is a full day symposium, but in summary, it's only a few words and sentences. So in the interest of time, we will have a 25-minute brief discussion. So I will talk about the commonality of 4 presentations. Number 1 is patient-centeredness, and patient experience is also important, and care quality and barriers as well. So I think these are the common denominators of today's presentations. So as a moderator, I would like to ask or appoint some speakers to give us an answer so that we can be punctual on time. So my first question goes out to Ms. Dr. Shin.
말씀하실 때 patient safety의 국제적
So in your presentation, you talked about, or I would like you to talk about the patient experience, and you also talked about patient-centeredness. So you know well about the Korean situation in regarding patient safety. I think we're in the beginning, early stages. So in your opinion, the patient-centeredness as well in utilization of healthcare data in a faster and more significant manner, reporting could be done. But in an opposite note, will this data improve us better reporting? So up to this point, from the supplier perspective, wouldn't this come back at me? So I willingly disclose information, but that could get back at me or that could backfire. Do you think this would be possible? So since you know well about Korea, what do you think the direction should Korea be in terms of patient safety? Any ideas for us to practice to undermine or eliminate disbelief in the system?
I said excellent question because I have been asked similar questions many times on international occasions, and my first answer is that, well, to achieve patient safety through reporting and learning system takes time. Our reporting and learning system in my country initiated 15 years ago or 16 years ago, and the initial couple of years, medical professionals, particularly physicians, didn't want to report for fear of being blamed, for fear of being sued by patient and family, or being blamed by Japanese media. And in the first press conference with the media, I was given a fierce question, strong question by media. They urged me to disclose the name of the hospital, to disclose the name of the medical professional. They said that They are a bad physician. They are a bad hospital in Japan. So unless I disclose the name of them, a patient visits the hospital. Patient visits the bad physicians again and again. But to promote patient safety, reporting and learning system do not work for blaming. So I didn't disclose the name of the hospital, and I again and again described the significance of reporting and learning system in promoting patient safety. It was like a lecture, and after a couple of years, there was no such questions. Then we observed increasing number of reporting and learning system, and the patient group didn't urge me didn't urge me to disclose the name of the hospital. So we steadily grew the culture of no blame culture in my country. I talked about the same thing in a WHO training education and training course for Maldives countries. So it takes time, but it's worth doing that.
감사합니다. 이어서 그러면
Thank you very much. And moving on to Dr. Luke.
이번에 저희 우리나라 헬스케어 시스템을 리뷰하시면서
In your review on Korea's system, I understand that you know pros and cons about Korean system. And what was impressive was that you're encouraging us to provide incentive.
인센티브
So when it comes to incentive,
모니터리가 있고 non 모니터리
there are monetary incentives and non-monetary incentives.
또 다른 경험이 많으실 텐데
I know that you have much more experience. So what kind of incentive would be better for the providers and government to help them to share their data more actively?
Thank you. That's a great question. It's costly to change the way you operate, the way you do things in any organization. If you are used to a scenario where you have your own medical record, your own data systems, your own data language, the way you code them and the way you use them. If an external actor, such as the government, whoever, comes in and says, no, you must now do it in a different way, there will be resistance. And there's only so far that the what we would call the stick approach, penalties, either financial sanctions or shaming in the media would work. What we would recommend is to assist places, organizations, hospitals across the entire healthcare system with some targeted financial assistance to convert their operational processes, their data management, their data governance, and their data provision back to HIDA and other agencies to make that uniform according to best practice standards, according to agreed standards across the whole country. So it's an investment that's tied to outcomes. So you would then require the organizations to prove that they are actually coding their data in a certain way, that they are collecting patient-reported outcome measures, that they are sharing these with other providers where the patient may go, and that they are providing these to the necessary agencies, such as yours. If that's not the case, then the funding can be withdrawn, and there can be other sanctions placed, so limits on how the scope of operations, for example, is something that that's been tried in other countries. So it's it's sort of more of a collaborative approach. We want to work with you to help you convert your processes to ones that make you part of a broader framework. Does that make sense? We would steer away from pay for every data point. So pay for data, we would say, it's counterproductive. It makes intuitive sense. Well, of course, then we will get more data, but it makes the relationship into a transactional relationship, and it implies ownership. It implies that the provider or the entity that has the data is the owner of the data, whereas in reality, it's not clear who the owner of the data is. Is it the patient? Is it the provider? Is it the funder, the agency who pays the money for the care? So, and then it may develop, pay for data may develop into a requirement to receive money every time that data point is used for research or for quality improvement or for performance monitoring. So, and given that the aim is to use data over and over again to learn, that would not be sustainable. So we would prefer a collaborative approach of investing to change and monitoring that change with some clear process and outcome metrics and adjusting based on that.
네, 감사합니다. 이어서 제가 연관 질문 하나 더 드리면 인센티브도 중요하지만 또 뭘 지적하셨어요?
To follow up, you also pointed out that distrust in Korea was very problematic.
모니터 밸류는 non 모니터
So monetary and non-monetary value is there, but then maybe I don't trust you, and how can I provide the data to you? And to overcome this, what should we do?
Yes, well, this is probably the million-dollar question. These behaviours and attitudes seem to be very deeply embedded, and I would say it will take time. It will take time, and it needs to be based around a common strategy. This is why we had a national strategy as probably the top recommendation. There you have a goal, an objective where you try to achieve as a country, as a health system altogether, and it's a roadmap as well. And the roadmap is not the plan is not let's just get straight to the destination. It will have several points along the way. So break up the journey into small, manageable pieces. I think that's the best way to go. And as we say in the report, when you are establishing new entities or changing the roles of new entities, you need to make sure that every stakeholder is represented and has a say in the new arrangements. So providers, patients, civil society, government, everybody has input, academia, everybody has input, and don't try to do too much at once. Go slow. It's the best I can do in a few minutes.
Yeah, right. 그래서 저희가 좀 시간이 좀 필요할 것 같습니다. 그러니까
So it seems like it will take time. It's a time-consuming process to build trust in order to trust each other, to make sure that this is a partnership. So if incentives are to be given, it could be in a monetary way, but we also need to consider the emotional parts as well. So having said what I said, question to Dr. Chung is, Dr. Luke also mentioned to secure simple data. So as you all know, this is not easy. So my question to Dr. Chung, so if we have more data, it will become more efficient, but why isn't it working? The stakeholders, not only the hospital, it's KCDC, HERA, and NHISS, and the cancer centers or public organization data are hard to collect in one place. So there's inconsistency and cooperation is not as much as we want. In order to solve this issue, what should we do or what could be done? Because these thoughts would contribute to improving the quality of care. So in order to do so, data is necessary, but it's hard for us to collect data. So KCDC and HERA is one of the partners of Dr. Chung, so we would like to hear from you. Thank you very much for your question. I feel like I'm being asked by my professor and evaluated by what I'm going to say. So a lot of pressure. But as have been mentioned, the distrust in the Korean society has been prevalently mentioned. But in terms of data sharing, I think the shortage of distrust is also an issue. So it's because there are less trust in intergovernmental levels. It's also between the researchers. And across the researchers as well. The data provider and the user is very different under the current context. And if we talk about data, it's fragmented. So in order for us to use it, we need to bring it together and merge it. So that has been one of the focuses of my research. But number one, the intergovernmental leadership or the ownership has been part of the power struggle. So once this data has been shared, how are they going to divide the accomplishments and achievements? So when we talk about data, the size is very different. KCDC data is only 5 gigabytes nationwide, which means most of the data is held by HERA, more than terabytes. So this data needs to come together, but essentially, if KCDC, or it could be said that KCDC does not have the capacity to process this big size data, which means that they need to use a source from HERA. So in terms of utilization, KCDC takes a leading role. So, which means that the hard lifting or the heavy lifting is done by all of the other organizations, but the accomplishments would be taken and claimed by KCDC. So there's this issue. And number two, so KCDC and HERA, would they be able to reap outcome with their own help? No. They will need help from external researchers, but among the researchers, everyone wants to put their hands on this data. So who should be first? Who should take what opportunity is also part of the debate. And in the early stages of pandemic, the confirmed cases were very high, but even so, we did not have quality data. So trust is not so existent. How do we need to address this issue? I think we need to try it first. We need to make attempts, try it, and then adjust with each other. And as for the complementary areas, we need to come together to solve it. But in the near future, we need to think of practicals and pragmatic agendas first. I think prioritization would be key under the circumstances. So the biggest issue is like Lageberio, the oral medicines is being distributed to our people, but the effect or the adverse effects data is only collected through HERA, which means that we need to first solve the issue that we are facing with and then slowly build trust, because trust building is a time-consuming process that will take a lot of time. And we need to share the achievements, so the researchers within an organization and between organizations would be able to trust each other more. So I think there's no get around to this issue. It will take time and a lot of efforts need to be put in. And this, only by doing so, it will be helpful to our citizens as a whole.
좋은 대답 감사합니다. 그러니까 결국
Thank you for the answer. So ultimately, we need to build the trust, and in the beginning, we need to be sharing common sense about the transaction, which will build into trust, so you can have a debt based on promise.
기회가 되는 거죠. 근데 우리는 앞에 있는 현금거래도 한 적이 별로 없고
But then at the moment, we haven't really had any transaction based on cash, so we cannot get any bond based on promise.
우리 두 분 외국 전문가들 와 계시겠지만
We have two guests from other countries, and they told us that you have the best data set and the usage rate is high, but there is a room for improvement, so why don't we try more? So in that perspective, although I belong to HERA, but for HERA, NHIS, and KCDC, and Cancer Center, I think we all can gather together and try something new to change. And the reason I am not asking a question to Mr. Choi is that because he also worked for HERA, I am keeping him for the last question. And for patient experience, we are doing QA, and there's a suggestion for social network service. So using Facebook or TikTok, we are trying to do patient experience survey. Is there any precedent, and will there be problem when we do that? I'd like to ask to Luke and Professor Shin, and then I will go to Mr. Choi. So what do you think about this, Dr. Shin?
Okay, asking about data collection on patient's experience or patient journey through SNS, right?
Yes.
Yes,
TikTok,
okay.
like in the Facebook. If I send an email, I tick.
Yes, exactly. Yeah. Actually, it has not started in my country at the national level, but I know that it has already started in some medication therapy like chemotherapy. When patient feels something different, or they noticed adverse reaction at home, they report it to physicians in charge of the patient through SNS. So it's sort of a research project, so it's a small scale, but it's actually initiated. And when I joined in international meeting or ISCA conference, there are many presentations on small research level presentations. So I believe that there is a big shift, the big movement toward the patient reported outcome, patient reported adverse drug reaction. So we need to catch it. That's my view. But in my country in my opinion, my country moves very slowly now. So we need to accelerate our action. That's my view. Thank you very much.
Yes.
Do you think it's possible?
It's a very interesting topic. We could spend another half hour, but I'll be very brief. And I'll start by saying I would be very careful to use media like TikTok, unstructured feedback on healthcare, on the quality and outcomes of healthcare. This will definitely anger clinicians and providers who are already very skeptical of patient-reported outcomes. I would be very wary of making it like a Google review or a restaurant reviews that you have, because the only way it can work if it is based on validated tools that are administered, consistently in the same manner for every patient. And we know they work. We know that directly it works to get information from patients, improves their outcomes. They've studied this in the United States with cancer patients. Those that provided PROMs on a weekly basis had longer survival times because the clinicians had more information to improve, to adjust their care. And I think, going back to your question about incentives, I think this is how it should be framed. Right. This is a way to improve the way you practice medicine. This will help you become a better doctor, basically. If you ask patients how they are feeling, what they are doing, using standardized surveys. This is not to say we can't use, a person with a hip replacement has a movement monitor, and we can track over time how many steps they are doing every day. That's objective. That's okay. We can do that. But I would steer away from people just free text, verbal feedback about their care that would not wash well with the clinical community.
Thank you very much. So, to some extent, it's a creative idea, but there could be backfire. So, what do you think, Dr. Choi? So, you do not have to represent HIRA.
The patient experience survey at HIRA, we have planned to diversify the methods, and one of the methods would be using mobile web and app. So they are under review, and I'm not aware of the full detail, but social network would mean that there's a wide spectrum about social networking services. For example, messengers that could be incorporated. Sometimes Facebook and TikTok, this is this can be exposed to anyone, which is just a pure social networking service. So I'm curious about which method you meant, but personally, I think the traditional phone call survey became more difficult to collect honest answers from patients, and the response rate itself is very low these days when we call them. So to increase the convenience of patients, we are trying to find new ways. However, as we heard from two experts, Mr. Slawomirski said that patient experience is mixed with patient satisfaction, and it's considered subjective at the moment. And the providers have this stereotype about it. So patient experience survey, if we want to adopt a new way, we need to consider LEDT's problem. And to my understanding, at HIRA, there are many researchers and collaboration initiatives with very cautious approach. I think, Luke, you want to add?
I just want to clarify, I'm definitely, I would say, in favor of collecting the information electronically through an app or on the internet rather than telephone or paper. It's just the method and the process, the questions that are asked, and whether they are part of an online discussion, I would steer away from that. They still have to be validated, structured questions that have been tested and as objective as possible. But certainly, yeah, we can reach people through social networks. You can collect them through social networks, but the surveys themselves have to be standardized.
Thank you very much. I think we're having a very interesting panel discussion, but it is time for us to call it a day. So thank you very much for your participation. We also shared lunch with the presenters from Denmark as well. So technically, I think the sky's the limit. So in today's symposium, what I would like you to remember is technology is not human. It is to implement what humans do. So if we do not have belief and mutual trust, technology will not be able to back us up and what we do. So the director of Denmark in our personal exchange said that there are no technical barriers, but if you're not able to move forward, it's because of the lack of trust and there's no experience in mutual cooperation. So this symposium is not necessarily only for HIRA, but I think it will resound to the staff members of HIRA. As a family, we need to wait for it, for trust to be built. We need to have patience. We need to share with each other. We need to build cooperation experiences with each other. So it will take time. So we have been an integrated system and we have been pushing forward over the last 2 decades. So we have more builds up. We do not have any technical limitations, but still we need to be patient. So thank you very much for your participation till the very end of this symposium. So this would be the end of today's symposium. I will see you next year. Thank you very much.